Good afternoon. Today we're going to do part 2 of our musculoskeletal system disorders, and this is going to be on connective tissue fractures. Bursitis, once again, is the first one we're going to look at, is inflammation of the bursa. Etiology is usually injury or overuse. Our signs and symptoms, we're looking at mild to moderate aching, pain, swelling. Maybe they had a history of injury or physical examination. The doc's going to look at like, yeah, you've been working too much. Could be like a carpenter or something like that. Treatment, we're going to use rest, ice, and massaging it. Resting it so it doesn't inflame more. Ice to shrink down the swelling. And massage was, once again, just to help with the pain. We're going to give them anti-inflammatories, and remember, we're going to give that with food, and that'll help with the pain and inflammation. We're going to wrap the extremity, and remember, we're not wanting this too tight, but snug. We're not using this as a tourniquet, but just tight enough. And then if that is not working over time, the doc may choose to inject cortisone injections in that area to help with the swelling and stuff. Nursing management, we're going to assess for the pain and perfusion. Pain, making sure that the pain medications that we are giving is adequate, it is covering the pain, and they're not having additional pain. And perfusion of that area as well. Once again, is it pink? Is it hot? Has it swelling? Because it could be other things going on. Assist with mobilization. Once again, we're going to rest it, but we still want to move it some. And then activity limitations. Once again, that'll be up to the physician, but we're going to try to limit the amount of movement to try to allow that area to rest. Other areas, a connective tissue disorder, rotator cuff. This is more in your shoulder. If you recall, you have tendons and ligaments in your shoulder holding your humerus together, allowing it to move. Your anterior cruciate ligament and the meniscal injury, both of these are actually in your knee. So once again, those are those ligaments, tendons, and they're keeping your knee together. And so it depends on how much of a tear that is. If it is extensive, they may end up having to do surgery on that. And then you have Achilles tendon rupture, which is the back of your heel. Once again, it all depends. Maybe just resting, or it could be requiring some surgery. And then the bunion, once again, that is more like your large toe where it goes lateral and causes some swelling and pain as well. Our next one we're looking at is carpal tunnel syndrome. This is because of compression of the median nerve. Just think about your ergonomics. We're at the computer and having your wrist always in a upright position that can cause some swelling and tenderness, and causing the swelling actually compressing on that nerve, that median nerve. Signs and symptoms, we're looking at pain, numbness, tingling of the hand, particularly at night, and this is often because of repetitive movements of the hands and the wrist. Keeping on with the carpal tunnel syndrome, the doc's going to look at it, look at the wrist area. They may do a compression test and electromyography test, which is more of looking at the muscles and the nerves electrically and seeing if there is nerve damage going on. Treatment, we're going to rest and definitely splinting. And remember, splinting, we want that splint on there snug and not too tight. We're not here to cause a tourniquet, but enough to support the wrist, and keeping it in one moment, no movement to it, but in one position, a resting position. Changing the angle of the wrist during repetitive movements, that's the problem. And if you don't, we're going to cause problems. if the splinting does not work, the doc may choose to do steroid injections. So that's like the next step before they want to go in and start doing surgery. And once again, if we do surgery, we're going to look at neural and peripheral vascular assessment. You know, the numbness, the tingling, looking at the capillary fill, the color of the fingers, and the warmth of the hand and stuff. Once again, here is our assessment of peripheral vascular assessment and neurovascular. Peripheral vascular, you're looking at the color, the temperature, capillary fill, pulse, and the swelling. Neurovascular, the 5 P's. I have pain, pulse, pallor, paresthesia, which is can you feel, and paralysis, can you move it? So that may be an issue. Once again, this is just a item here, more of a visual for the 5 P's. Talks about the pain, the pulse, the pallor, paresthesia, and the paralysis again. Fractures. Once again, here, we know this is an interruption of the continuity of the bone. It could be from trauma, osteoporosis, and metabolic problems. Signs and symptoms could be minimal to severe pain. It all depends what kind of fracture it is. Is there swelling? Is there bleeding? There's going to be tenderness, deformity of the bone. That area is probably going to be very bruised, and you may feel some crepitus underneath the skin as well as loss of function. Diagnosis we're looking at is probably x-rays. Doc's going to look at it and say, yeah, let's look at an x-ray, and the x-ray is going to show us, is there a fracture and is there pieces of bone out there that may need to be removed as well. Here is a list of types of fractures. Once again, you've got complete, incomplete, comminuted, closed, open, and green stick, which we will look at specifically. And here they are. Pathologic, a lot of times could be from tumors and stuff. I have longitudinal that goes along the bone line, up and down. Spiral goes in a circular fashion. Oblique kind of goes sideways. Comminuted looks like it's more like a crushing. You come down on your leg and it comes down on itself. Transverse, it goes right across. A simple break, and a compound is the worst one to have as it breaks through the skin. Older adults, once again, are more risk at fractures because of decreased reaction time, failing vision, less agility. They're not as mobile, they're not flexible, and they also have issues with balance as well. So remember that, and they're setting themselves up because they do often have GI reflux, so they're probably going to be on some type of Prilosec or proton pump inhibitor, which I believe actually inhibits them to absorb that calcium over time. Treatment for fractures, once again, emergency care. We're going to treat shock and hemorrhage first. If you do come across and somebody has a fracture, make sure that you are splinting the fracture as it lies right there. Do not attempt to realign the bone. If the person has not had a tetanus within the last 5 years, they typically will give them an injection for that. We'll probably start them on prophylactic antibiotics just as a possibility of infection because of the break in the bone. Reduction, so we can do it by closed, open, and we can do it by stabilization as well. With the internal fixation, we have pins and nails and metal plates that the orthopedic surgeon will put in. Open reduction and internal fixation. So kind of think about your the hip, ORIF of the hip. They will take it out, remove the top part of the hip, put the other one in, and fix it that way. Intravenous antibiotics. they'll be giving them. But remember, nursing care, you have to have good alignment. So not only are we going to be focusing on the incision, we're going to be focusing on the alignment of the leg or the arm or whatever we're working on, and making sure that it is straight and in proper alignment. We want to make sure those muscles are healing as well. Examples of internal fixation, we're looking at hardware here. We have pins going through the bone. We have, looks like safety pins that are going through the bone when it's the fracture goes through, kind of like oblique. External fixation, once again, indications would be more of massive open fractures and extensive soft tissue damage. Infected fractures that don't heal, multiple traumas such as burn, chest injuries, or head injury. So this is where they actually go in and have pins. The hardware is actually on the outside. So, and here is an example of that. The hardware is on the outside. So these pins right here are actually screwed into the bone, and you will need to make sure that you do a meticulous skin care with those pins at least once or twice a shift, and make sure that they're clean at all times. This extremity must be in a appropriate alignment at all times as well. So we also talked about that, nursing management, about the pin site. Pre-medicate for the pain. Once again, it can be very painful. We need to make sure that we're wrapping the leg or the arm before showering. And then they will do physical therapy because we're going to have to keep up with the strength, and assisting them with ADLs as well. Here's an example of some casts as well. Once again, make sure up here around the skin at the top that we're going to watch for skincare up there, any rubbing, sores, open areas and stuff like that. And then also down here, we're going to watch for the toes. Once again, here's your 5 Ps. Looking at the color, cap refill, the warmth, the pulses, do they have numbness and tingling? Is there swelling going on? So that is what we're going to be watching for. Moving on to braces and splints. Once again, fractured boot, hinge brace, and slab. All depends what the doc or orthopedic surgeon is wanting to use. Definitely key thing is patient teaching. We're going to explain the procedure. Feel warmth as cast sets and dries. That's normal. We're never going to put a fresh cast on plastic, and we're never going to cover a fresh plaster cast with a blanket either. Those are issues that can cause problems. Here is an example of a walking boot as well, where the person can actually possibly walk as their fracture is healing. Now we're going to move on. The last few slides is traction, skeletal traction and skin traction. They are actually pins and wires, tongs directly through the bone. This is for skeletals because what they're trying to do is align the fracture up, the bones together, and then actually help with this muscle spasms and stuff because we're stretching the muscles out to get them to quit cramping all up. So typically this is going to be using more than 10 pounds of weight, and the body is kind of like that counter traction as they try it. Skin traction, no more than 10 pounds. Okay, so they have a moleskin foam traction boot that's on the extremity, and they pull on that and not on the leg itself. Here is some common types of traction. Here's a Buck's traction. Here's a Russell's traction, where it's this one, the Buck's is like straight. They have the foot wrapped and they pull it that way. And then Russell's kind of like a counterbalance going on as that. And then pelvic traction, where they have like a brace that goes or wraps around them and they pull them on that way. And then balance suspension, once again, it's pulling on. You got a brace around the leg, and then it's there's a balance. Leg is on a platform where they actually pull that way as a balance.